I love scanning the scan post and the scan body in the mouth. It's very accurate. I get great tissue definition, and it's also timed very well, meaning that the scan body within the software has to be timed in the way that we fit the scan post and scan body into the mouth. If that's not timed right, if it's just several degrees off, your final restoration is not going to fit. So that's really, really important. But to mill these restorations, make sure the emergence is on, finish the restoration, cement it on the tie base, and screw it in, particularly in a solid abutment crown. That's more realistic in one appointment. But anteriorly, if I'm doing a two-piece restoration, I'm going to usually not place that in one appointment. So the process for scanning a scan body on a scan post is really easy. You go ahead and take the healing cap off, you screw in the can post, you make sure that you align the outside indicator on both the scan post and the scan body, so when you fit those together, the timing is right on. And I'll tell you, this is very, very accurate. I've compared it to both traditional type of impressions, pouring it up in stone, making it on that situation, using the scan body on a stone versus a scan body in the mouth. And I'll tell you, the mouth always wins. It's very, very accurate if we do it right. So it's real important to get that timing on. To take the optical impression with either the blue cam or the OmniCam is really easy. It's just normal. You just go ahead and scan the arch. Now, one thing I'm looking for is to make sure I have a gingival mask impression. In my clinical theater, in order not to lose that soft tissue emergence, once I take that healing cap off, I put in my scan post, put my scan body on that, and then I'm scanning. I want to capture that soft tissue emergence. Now, to get my gingival mask, I'm going to copy that over to my gingival mask catalog in the imaging acquisition screen, and I'll just cut out the implant, still maintaining that soft tissue emergence. It's really easy to get your gingival mask that way. Then we scan in the posing arch and also the bite registration with the scan body off. If the scan post and scan body are in place, the patient can't bite down. If you look at the literature for implants, our final restorations have a biological width. They have a horizontal biological width and they have a vertical biological width. The vertical biological width is somewhere between 3 and 4 millimeters. The horizontal biological width is dependent upon whether it's a switched platform or a traditional type of emergence. A switched platform is when the abutment emergence out of that implant platform, it's smaller in diameter than the implant. The current literature is showing that the switched platform has some advantages. But in addition to that, this is critical of this conversation. We'll get more into the switch platform and some of the emergence issues in another video. The real important portion of this conversation is we don't want to continually remove the healing cap and fit an abutment and go back and forth. If we can place the abutment with no more than removing the healing cap more than 3 times, the connective tissue attachment has a tendency to stay on the abutment and not drift down onto the implant platform, which means you're going to potentially get more vertical bone loss. There's more to come on.